Good afternoon, or good morning, I guess it depends. I'm Dr. Roa-Navarrete, and this is the first segment of the Special Populations class, Special Populations 2. This is a recorded lecture for the topic of the first segment of the course, which is going to cover the topic of ethnicity. And I've given you an introduction to myself in a brief video that was posted to the announcements sections of the portal or the Canvas portal. So I won't reintroduce myself here. I do hope that you guys take the opportunity to uh, give an introduction of yourselves and to share a little bit about your background in your interest in psychopharmacology when you post your own recording or when we get to meet for a live lecture next week. Again, my name is Ruth Roa-Navarrete. I'm happy to be here, and we're going to cover the topic of ethnicity today. I want to make some course announcements in general. This is the beginning of another 8-week course, so this is a good time, or as good time as any, to go over some ground rules. First of all, I'm a clinician, and have been a clinician for 20-something years, so I am very much used to a 45 to 50-minute hour, which means my legs have to stretch, my body has to, change positions, and I have to take a break about every hour. I also have to stay hydrated, and you know what happens after that. So that means that for every segment of lecture, there's going to be probably about, for every roughly 1 hour segment of lecture, there's going to be about a 10-minute break. I do both in the recorded, which doesn't matter so much, as well as the live lecture. I do try to hold very much to the schedule because I don't want to make anybody wait. So our breaks are going to be about 10 minutes for every hour. Your topics that we're going to discuss this class for this class are ethnicity, substance abuse, and gender. And this is an advanced course in that you have taken all the basic classes or most of your basic classes, and I know you're nearing the completion of your program, which I'm sure you're very excited about. So with that, I think it's important to just kind of remind you that part of the information that we cover in this course should be a review, perhaps with a different lens or perhaps with a different way or viewpoint, and perhaps with a view to a more practical application of some of the material that you have already covered in other classes. And not just in your psychopharmacology degree, but obviously in your psychology degree and other continuing education. So I do not propose that everything we tell you, Dr. Nichols and I, is going to be brand new to your ears. But I do propose that we're hopefully going to present you with information that has practice and clinical applicability to the role of a prescribing psychologist or a psychopharmacologist, into viewing this new area of practice for you, hopefully an area of practice at some point in the future, from a different perspective, or from that perspective. Let's put it that way. Another ground rule is participation is welcome, highly desirable. So I know that we can't really have live participation in the recorded lectures, but anytime you want to send me an email or a text, well, I guess not a text, but a message through the Canvas portal, please do so. Anything you want to share with the rest of the class, you could do so also in the Canvas as needed, or if you want to send me a private email, that's fine as well. When we are meeting for live lectures, I do hope that you guys unmute your microphones and come on camera. If you feel free to do that, it'll make me really happy because it'll feel more interactive. If you don't, that's fine. Just at least, pose your questions in the chat and I'll get to them as quickly as possible. Likewise with email, text, or Canvas, I'll try to get to them as quickly as possible. And every year I run across questions that are areas where I haven't had that much experience or I don't know the latest or greatest just yet. So please just keep in mind that I'm a lifelong learner like you are. So if you have a question that I don't have an answer to, I'll try to get you an answer. It just may not be something that is immediate. Um, Next thing to know is that there are discussion posts that are required for this class every week of the class. And so it's important to keep in mind that Wednesday is the deadline for your own post. Sunday night is the deadline for responding to at least two of your classmate post. And by what I mean, I want to clarify what we mean by responses. Those are critical responses and not necessary critical in the sense that they have to present an opposite viewpoint, but they really have to analyze, evaluate, and critically uh, take into account the information that your classmate is providing and adding something more. There is a rubric for grading those discussions that is posted in the class materials in Canvas and in the syllabus. So please do review that. Keep in mind you may not get full points if your response it doesn't meet the criteria in the rubric. And if it doesn't and you need some feedback, please let me know. But just understand that, the more you put in, the more you get out. So just do keep that in mind. Um, Other than that, I think that that's all for class announcements and maybe more when we meet in person. I definitely want to, we'll be asking you some questions when we meet, well, not in person, but in live lecture. And I'm sure you're going to enjoy meeting with Dr. Nichols as well for the substance abuse part of the course, as well as when we meet together to go over case discussions, which will be an integration of all the topics discussed in this class. So with that, let's go ahead and get started. So what we are, well, let me just What we are going to talk about is transcultural psychopharmacology, and also known as special populations to ethnicity. So just to give you an overview, what we will be covered in day one, which is, this recorded lecture, will be a review of the PEP knowledge domains. And I know this is the time when, people's anxiety starts to increase when I talk about the PEP, or the psychopharmacology exam for psychologists. The key here is that we're not, this is not review for the exam. Hopefully you guys will have the opportunity to do your review class and, get some studying under your belt. I do have some recommendations about when and how to approach the PEP, and I may be, peppering those recommendations throughout. And of course, if you have any questions, let me know. But what I'm interested in is to let you know how this course, how the materials that we cover in this, the topics that we covered in this course are going to be relevant to the PEP and what you need to know to be able to pass it. And then we're going to get an overview of what transcultural psychopharmacology is. To start with the why, why do we want to learn this? Why is this important? How do we get the knowledge, the background knowledge necessary to be culturally competent, which is the next topic. We're going to talk about cultural competence and the different aspects of what it means to be culturally competent. We're going to talk about transcultural psychopharmacology and genetics, including talking about pharmacogenetics, environmental factors, genetic polymorphisms, which again, I know you've covered in other classes. Hopefully we'll be talking about it both as a review, but also with an eye to, giving it a practical application to the topic at hand. And then we're going to talk about phenotyping and genotyping. And that is probably going to be the bulk of what we cover in day one. Day two, which is a live lecture, includes talking about transcultural psychopharmacology as it relates to culture-specific factors from major ethnic groups in the United States, including the five that you see listed in front of you. And obviously, this is not an all extensive list. I've considered over the years, and I've added over the years material, keeping in mind the relative numbers associated with these populations and how you, whether or not you may, whether you may or may not interact with these populations in your daily practice. And of course, I don't know where you practice, so it really all depends. But as they are the five major ethnic groups, meaning the ones with the largest numbers in the U.S., those are the ones that we're going to cover. Needless to say, we rely on a lot of information that is as it's broadly generalized and potentially stereotypical, and I'll make some cautions and warning statements about that as we go through. But also we're going to talk about things that have applicability to other ethnic groups as well, in the sense that a lot of communities of color, communities that have similar backgrounds when it comes to migration or underserved, marginalized type of status, share some commonalities with regards to, specifically with regards to culture and how it affects their healthcare. So keep that in mind. And then the guidelines for transcultural psychopharmacology is actually something that we're going to talk about in the following class. So we may not get to it in day 2. It might actually be day 3 as we end with that, and then transition into covering the gender portion of the class. All right. So with that, I want to make a disclaimer. Well, a couple of disclaimers. If you watch my introduction, I introduce myself as a retired Air Force psychologist. The majority of my clinical practice, especially the practice that has included me being a prescribing psychologist, has happened in the Air Force as an active duty military psychologist. And therefore, I do have to, make, as we talk about cases specifically, and as we talk about things that are relevant to, clinical experience, I want to emphasize that, what I'm sharing are my opinions and not those. I'm not here to speak for the Department of Defense or for United States Air Force policy specifically, though I may share it. I am not giving you the official answer. They have spokespeople for that. I also want to emphasize, and it's important, especially, in this context, to emphasize that I do not have any financial ties to any pharmaceutical or medical device developers or manufacturers that we're going to definitely discuss in this class. And thus, I call myself an equal opportunity criticizer. But I also give praise when praise is due, and that is mostly based on either, knowledge from research or clinical experience. And I'm happy to share my opinions, but just letting there are no financial conflicts um, to make me watch what I say in any way, shape, or form. Okay. So with that, let's talk about the psychopharmacology exam for psychologists. And again, I understand this may be anxiety provoking. Some of you may already be getting ready for it. Some of you may have contemplated whether or not you're going to take the exam, if at all, especially if you live in a state in which, prescribing privileges are not yet available for psychologists. But in any case, I think it's a good idea to consider how to sort of integrate all the material that you cover in all your different classes and understand why it's relevant. The knowledge domains were last updated in 2023, so I'm giving you the latest and greatest. There wasn't much change from the last update, and I couldn't tell you when the last update was. So know that, even if you decide you're going to take the exam in a couple of years, these should still hold pretty true based on what we know. Also, I said that I was going to pepper some recommendations about the PEP. One thing that I ask you to consider is whether you're a person who learns by, reading, reviewing, memorizing to some extent, because you will have to, or applicable application demonstration and doing. So if you depending on your strengths or weaknesses, maybe not a weakness, but preferences, potentially consider whether taking the PEP before or after your practicum makes sense. Before, you have the benefit of all the knowledge being fresh in your head from all the classes that you've taken so far, and that you'll continue to take until the end of the program. After, you have the benefit of not just having that foundational knowledge, but the applicability in clinical practice, which can be very beneficial. That's how I learn best, is when I can apply it, put a face, quote unquote, to the syndrome or the problem or the medication, the side effect, and all those things, help me. Not to mention, of course, that I still had to review and, do practice exams and all that good stuff. Okay. So there are several content areas that are relevant to the PEP, and that percentage that you see listed here is the percentage of questions that is specifically focused on those content areas or those topics. What I want to emphasize is that they tell you, they do advise you beforehand that I don't. Uh, Maybe the best way to explain it is this. While the one question may be primarily focusing on the area, for example, of content area one, integrating clinical psychopharmacology with the practice of psychology, that doesn't mean that they won't have another content area that is relevant to the question as well. So a lot of the questions touch on more than one content area. And so those percentages are a little bit irrelevant in that, as I said, it's integrated knowledge that they're looking for. So multiple questions will cover more than one content area, perhaps even not just two, but perhaps even three. Just keep that in mind. So as you can see, the first content area is integrating psychopharmacology with clinical practice. And and there are different topics that are, relevant. I've highlighted in red, and I don't necessarily need to read this for you, but I just want to highlight in red the importance of understanding biopsychosocial variables, including family history, patient belief systems in their culture, economics, poverty, social support, and current environmental circumstances, all of which we're going to cover to some extent in this course. Another topic related to this integrated content area includes the limitations and benefits in patient perceptions, which is really an important area to consider when we're talking about cultural competence, including things like help-seeking attitudes and treatment expectations. Not everybody is going to respond to the same treatment by the same provider, and part of that has to do with cultural beliefs about either the act of help seeking, cultural beliefs about the relationship with the therapist or the provider, and treatment expectations in general as to, whether or not it should work. And then again, you can read the rest of it for yourselves. More about content area one, and we're on slide 8, in case you're following in your notes or note materials. Talks about the knowledge of practitioner patient partnership, is what I talked about before, the idea that not every patient is going to respond the same way to the same provider. Including the impact on patient education. So how important is it to provide psychoeducation and to really have an informed consumer, which I'm going to talk about several times over the course of this class and in my next class, or my next topic, which is gender or sex. Adverse effects in response to side effects, and again, cultural variables, and as well as potentially genetic variables that have to do with this. And implication of for the relationship of psychosocial variables. For example, once again, ethnicity, culture, socioeconomic factors, religion, refugee status. Again, areas that we're going to talk about. Likewise, knowledge of the development and implementation of a coherent and organized treatment plan. in that treatment plans that include psychosocial, cultural, including the participation of traditional healers when appropriate, in pharmacological interventions. Again, I don't think I need to expand too much on that. Uh, Content area too, and I don't remember exactly what it is. I think it's neuroscience and neuropathology. I maybe off a little bit. Doesn't really have anything that is relevant to this course, so that's why I've skipped it. Not, it's not an error, so I just want to make sure to point that out. But content area 3 talks about nervous system pathology. Again, you can see about 11.3% of the questions touch on this. Again, there's overlap, so you may not get to a perfect 100 here. But this one talks about the knowledge of etiological factors in diagnosis of chronic pain, including headaches, including things like migraine and versus non-migraine headaches, neuropathic pain, and fibromyalgia. And the reason that I've highlighted this specifically for nervous system pathology is because it is relevant. There are some cultural factors as well as gender-related factors that are associated with the perception of chronic pain, or even the prevalence of chronic pain. So we're gonna, and other such diseases. So we're gonna talk about that. Likewise, common knowledge of common iatrogenic or drug-induced movement disorders. Their etiological factors, signs, symptoms, and diagnosis. And with regards to things like extrapyramidal symptoms, dystonias, etc., there are ethnic and gender variations, and so we're definitely going to cover that. On slide 12, we address knowledge of nervous system pathology, including several samples of diseases. And the one I've highlighted here specifically is exposure to environmental neurotoxins. You probably know from your, from just general knowledge or from even from previous experience that exposure to environmental neurotoxins is, excuse me, is much more of an issue for marginalized, underserved communities of color in general, because they do tend to live in areas that are more rural, or potentially even industrial in more urban areas where those exposures are present. In content area 4, we talk about physiology and pathophysiology. That's a good chunk of the test. And again, you're gonna learn a lot about this in other classes. The knowledge at a functional level of renal, genitourinary system physiology and pathophysiology across the lifespan, and their relationship to psychopharmacology and psychopathology. But one thing that I've highlighted here is their role in excretion of wastes in medications. So essentially what we're talking about, things like first pass metabolism, the interaction between psychotropic medication and liver enzymes, such as the cytochrome P450 system, infectious diseases such as hepatitis and alcohol use disorder, which tends to have some cultural correlations, at least to some extent. And so obviously those are, things that we need to know about or take into account. Try, look at it from this perspective. In content area 5, we look at biopsychosocial and pharmacological assessment and monitoring. This is, the nuts and bolts of, basically a biopsychosocial assessment. Including things like how to do an individual and family history, how to take an individual and family history, what areas to assess for, and that are relevant to prescribing. And I will tell you, from personal experience, you know how to do a biopsychosocial assessment. If you've been a psychologist for any amount of time, even if you're just newly graduated and, just got your license, this is something that we trained you on, graduate school trained you on, your externships and internships and your post doctoral, if you did one, they trained you on how to do a biopsychosocial assessment. But doing one that is relevant to prescribing is different. And again, I tell you from personal experience, the first time I had to do a biopsychosocial assessment for a patient that was a potentially, a candidate for medication, I was not great. I didn't remember, that I needed to explore some areas that I would typically potentially not explore or just maybe gloss over in a biopsychosocial assessment for therapy. So, just keeping in mind that we have a different lens and we're going to apply a different lens to our practice going forward. So things like review of systems, dietary habits, behavioral observations, developmental history, social history, family medical and psychiatric history. Again, things that maybe we would ask in a cursory way before we're going to get more in depth about. And of course, including knowledge of diversity-related variations in the incidence, prevalence of disorders, both medical and psychiatric, as well as history of sexually transmitted diseases, something that you may or may not have, talked about with your patients before. Yes, you're going to more so than potentially in your previous practice, you're going to talk about sex. You're going to talk about sexual side effects. You're going to talk about sexual functioning, and you're going to talk about sexually transmitted diseases and potentially psychiatric comorbidities related to that. And it's a good idea to get into the mindset that you feeling comfortable and you exploring those topics is going to allow your patient to know that they can too. And they will. They will. Okay, slide 15. Again, more about the biopsychosocial and pharmacological assessment, and talks about how to do a basic physical and neurological exam, including the history of presenting problems or history and physical examination, a review of systems with variations for special populations, including people of minority backgrounds. So just again, one more way to emphasize, it could be different from what you've been doing already. More about that. This talks about appropriate lab tests and assessment procedures before prescribing medical or medications, particular medications, including gender and ethnicity. So, what lab tests may be appropriate for a person of a certain background? Is genetic testing appropriate or even necessary or required? Depending on what you're proposing to prescribe. And we're gonna there are definitely some examples that make this applicable to this class. By the way, this abbreviation you should know, TDM, stands for Therapeutic Drug Monitoring. Okay, content 6 relates to differential diagnosis. I didn't specifically highlight anything in this area, but you should keep in mind the different prevalence, incidence and prevalence rates, as well as the different perceptions of symptoms and whether or not they should be treated or targets for treatment in different cultural or ethnic groups. So while ADHD, for example, may not be uh, the incidence may not or the prevalence may not be different in different cultures. The way they view their symptoms, the way they interact with healthcare providers, the way their help-seeking attitudes and behaviors may be different. So obviously, we're going to talk about those things. But specifically, when we talk about differential diagnosis, we're going to talk about things that for example, the signs and symptoms associated with things like psychosis, signs and symptoms secondary to substances of abuse, prescribed and over-the-counter medications, most commonly used herbal remedies that have psychological effects, and dietary supplements. On slide 19, we go on to talk about content area 7, where this is all about pharmacology. So basically not just the drugs, but the effects of the drugs, both pharmacokinetic and pharmacodynamic. So talks about absorption, distribution, metabolism, and elimination. Again, things that we're going to cover in this class with an eye specifically because this should be a review to how they apply to minority populations, including discussion of the CYP enzymes, drug and drug and drug and food interactions. There'll be, something that we talk about. And knowledge of other factors like biological, ethnic, pharmacodynamic, genetic, pharmacokinetic related to intra and inter individual responses to medications. And one of the examples that are listed there, along with pregnancy and age, is obesity. So, we're going to talk about health status of different populations so that whether or not that's something that you need to be aware of for a specific patient. Slide 20 it relates to content or discusses content area 8, which is clinical psychopharmacology. Again, big chunk of the test, 16%, talks about decision-making with regards to psychotropic medication selection and use, including, titration, tapering, multi or, what's the name? What's the word I'm looking for? Polypharmacy or, prescription of more than one agent, augmentation strategies, that sort of stuff. And it's going to ask you to consider, things like genetics, ethnicity, cost, and limitations of current diagnostic systems like the DSM and the ICD or International uh, Code Classification, International Classifications of Disease, in terms of how they apply to the population at hand. In addition to they address things like dosing, time, course of therapeutic action, and adverse effects, and how to predict those based on patient factors, including their weight, their gender, ethnicity, culture, age, history of trauma, and other things that you see listed there for you. As well as that, we're going to talk about the knowledge. We're going to talk, this area covers psychological and physiological symptoms of common recreational substances and the management of intoxication or addiction. Something that we're not going to cover specifically in my segment of the class, but you'll be talking about with Dr. Nichols when you talk about substance abuse, of course. I'll briefly mention some substance abuse factors as they relate to, some of those major population groups that we talked about before. So just want to make sure to bring that up. But he is definitely the subject matter expert. So that's going to be an area where you're going to get most of your information from that segment of the course. Knowledge of the patient factors, including their culture, literacy rate, stage of change that need to be considered when providing psychoeducation, on providing patients information about drugs, risks, benefits, potential complications, and alternatives, because and that's something we're going to talk about when we talk about the guidelines for transcultural psychopharmacology, is the idea of having a patient interaction or a patient relationship in which alternatives are not just considered, but seriously considered, discussed, proposed, and evaluated with the patient, which is what potentially makes us different from other prescribers in that we have the time and we, value the relationship, rapport, and the relationship building aspects of our therapeutic relationship, and that, should expand or could definitely expand to the pharmacotherapeutic portion of it. And then just briefly, nothing specifically relevant, but in general, relevancy to the area of research. This is not the last content area, by the way, but research in the, your knowledge of research designs and analytic techniques used in pharmacological research. I believe you've had the class on research already. So what we're going to bring up is the limitations of the research. That's what we're going to talk about in this class, the limitations of the research as it pertains to the populations that we're going to be addressing, as it pertains to minority population, and later on as it pertains to women and other gender or sex minorities. Again, not a specific area, but all of it, to be sure. And then the last content area is content area 10, where they talk about professional, legal, ethical, and interprofessional issues. It covers 6.7% of the test. And this is an area, both research and professional, legal, ethical issues is an area where you probably have a better chance of seeing those topics interspersed with other topics in the PEP, where your question may be about pharmacology, but it also may touch on something that is related to a legal or ethical issue. Or it may be, posing the question in a way where, your knowledge of research practices, research designs, and limitations of research in in pharmaco or pharmaceutical development and FDA approval process may come in handy. So just keep that in mind. Once upon a time, there used to be a note in the PEP preparation materials that specifically made it so that basically everything related to content area 1, they made it clear that they should be considered as it applies to across all knowledge areas. So basically content area 1 is really the one to know best or to understand best how it integrates or how it affects the other areas. I don't believe that has changed drastically. They just taken the note out. So just keep in mind that things like, again, genetic, sex, age, psychosocial dynamics, including culture, ethnicity, ecological, and environmental factors are going to be, the lens by which all, potentially a lot of the other content areas are viewed. Okay, that's a lot about the PEP. So just and we'll again, I don't want to scare you. It may or may not be relevant to you depending on whether or not you plan to take it in the near future. But I wanted to give you the why. We cover this material not just in this class, but hopefully throughout the course to some extent, and then go from there. Okay, so we're going to move on to definitions. Sorry, I do need to remain hydrated. Okay. And again, this is an area where this should not be new material for you. Most of you have had, undergraduate and, definitely graduate courses in ethnicity or, cross-cultural topics. But this, specifically as it applies to psychopharmacology, here are some definitions. First of all, we're going to define transcultural psychopharmacology, also known as ethno-psychopharmacology, whatever is easier for you. And this is one definition that this field attempts to answer: how do culture and genetic differences of natural social groupings, so cultural groupings, of the human race determine and influence response to psychotropic medications? Once again, how do culture and genetic differences of natural social groupings of the human race determine and influence response to psychotropic medications? That's the hope. That's the goal. Do we have have we reached the goal? Do we have a clear-cut answer that we can give? Likely not. There will be some areas in which we have stronger knowledge base, but then maybe others where not so much. I'm going to tell you right off the bat, and you might want to. Right now, you may be thinking, "Why am I taking this class?" Well, because you have to, and two, because we do. We have a lot of knowledge. We also have a lot to learn. So in this field, we consider variations in pharmacokinetics and pharmacodynamics, as well as cultural influences. So once again, it's, both genetics and environment that we're going to be looking at, and the response to drugs among various ethnic groups. So that's our definition. That's also our goal. This is an old quote, but I think it still applies, that in this increasingly multicultural world, so this is not just relating to our country, but our world, we live in even more so than in 2003, we actually live in a global, or we have global, uh, what's, sorry, what's the word I'm looking for? Um, Global impacts, and global determinants, of, how we function, mental health, mental illness, et cetera, et cetera. Again, more true now than in 2003. So in this increasingly multicultural world, it is essential to make efforts to accomplish an effective integration of universalism, the idea that, the human experience may be universal, or global, which facilitates professional communication across the continents, and local realities and needs, which evidence the patient's singularity in his or her particular context. Sorry about the little background change there. Um, Once again, I'll give you a moment to digest this. Essentially, what I take away from this quote is that no matter how, again, how we are impacted day to day by a global economy, a global, knowledge base and experience, especially with the increasing impact of, social media and the internet, um, it is incumbent upon us to remember that local and individual um, factors also influence what the patient is coming to you. It's uh, coming with, what the patient brings to the table, what their life context is, what their experience is, and potentially what you might need to do for them. So think globally, think individually. What are some obstacles to this idea of being transculturally competent, specifically when it comes to psychopharmacological competence? In the past, and still true to some extent, over reliance on clinicians' anecdotal reports. So the subjectivity of, I've seen this once or twice, or I had a, Latino patient, or I had an Asian American patient who blank, and thus I'm going to treat every member of that group, or even other members of that group, with the same lens, just because of my previous experience. So a lot of reliance on clinical anecdotal reports as opposed to, once again, research. And that has to do with the limitations of research, of course, which is the second bullet there, the lack of vigorously designed studies, and also the lack of, you'll see some, significant variation in how ethnicity is defined, which makes it so that we're really comparing apples and oranges, and sometimes, apples and papayas, really, as opposed to, things that are truly similar or the same. Conflicting results in the studies that are available, economic and marketing influences and pressures, which is something that I want you to remember, because we're going to do a little bit of an exercise later on in this segment. And of course, really has to do with who pays the bill, right? Private insurance, self-pay, and who do pharmaceutical marketers and develops target when they think about how to treat psychiatric illnesses, or really any medical problems. And of course, bias, which is also subjectivity. Other definitions, just to put us all on, kind of an even playing field. By the way, we're on slide 32. I just realized that this is incorrectly number 27. So just fix that. But I want to make sure that we stay on track. So we're on slide 32. The definition of race is a distinct population sharing physical, genetic characteristics. So you heard me use the term human race before. Humans definitely have shared physical genetic characteristics. But as far as every other group, especially those cultural groupings that we talked about, maybe not so much. So I want you to think of race, especially in this context, as primarily a sociopolitical term or construct. As you could see, according to the Human Genome Project, people are well over 90%, 99% identical in terms of genetic characteristics, which means that at the molecular level, race is nothing. You can't you can't tell us apart. So once again, I want you to think about or consider thinking about how that translates in terms of how you read research or even how you read clinical reports, where the definition of race or the separation or even inclusion of race factors may be problematic in terms of, the results. You'll find that some researchers and some writers use the words race, ethnicity, and culture almost synonymously, even though they have very different meanings. So, for example, just to give you an example, Hispanic can refer to, in some contexts, can be defined as a race. It can be defined as an ethnicity, and can refer to people Puerto Rican, Mexican, Peruvian, you name it, Chile, Argentinian background, um, among many others, and describes, millions and millions of Americans. But some researchers, again, some writers have used the term to denote a racial category, despite the fact that Hispanics can be any race, including of African background, Asian, native of the natives, people of Central and South America, and of course mixed race and so on and so forth. So again, this imprecision in use of the terms raises a lot of questions about the accuracy of data that is based on racial definitions or racial characteristics. Also, something you need to think about is that looking at a person does not tell us their genotype. The degree, we're going to talk a little bit about, genetics versus environmental factors, or the degree to which an environment affects someone's genes. We don't know that just by looking at them. We don't know that just by knowing their nationality or their background, their family background, or even their migration status. So just want to make sure you keep that in mind. Okay, enough about that. I'm kind of sat on my soapbox there. Another term that we're going to differentiate here is the term ethnicity. And we define ethnicity as social groups with shared history, identity, and cultural roots. There is significant variation in defining characteristics of an ethnic group. It could be the country of origin, and it could be the region of origin, not the country per se. For example, if you're looking, for example, at the Middle East or even Eastern Europe, there are very regional variations that have to do with religion, like Muslims versus non-Muslims, or Muslims of a certain denomination, um, that have more bearing on the cultural identity of that group, that region, than their country of origin. So, it could be quite nuanced. Um, but, country of origin and the adherence to the customs of that country is something that we could look at as potentially, a variation or a factor associated with their ethnicity. And things like genetics, I mentioned, genetics, for example, Latinos, um, and African Americans may have European, African, and Native American ancestry. So, it could be an ethnicity But it's unlikely that we're going to be able to, uh, you know, classify it as a race. And then culture is or relates to the shared patterns of belief, feeling, and knowledge, as well as unique behavior patterns and lifestyles or lifestyle uh, shared by a group of people that distinguish it from other groups. It's characterized by a set of views, beliefs, values, and attitudes. And I'll give you an example. Way back when, when I got my bachelor's before I went into graduate school, I was a case manager in elderly care, essentially in South Florida, where there's a lot of elderly people. And part of my job was to do a little bit of a demographic and, basically a little bit of a biopsychosocial assessment to determine what their case management needs were. And as I was collecting demographic information, and most of this was done over the phone, I didn't do much in person. Um, as I was collecting demographic information for people, I would ask him about their race, I would ask him about their ethnicity. And there was a lot, it was very common in the Jewish American community to call themselves to mention their ethnicity was Jewish. So once again, ethnicity, or culture is a shared pattern of belief, feeling, and knowledge. And so you can understand why that makes sense in that context. And also, a community with unique lifestyles and behaviors to some extent. Um, it is really critical to understand that when we talk about culture, which is the term that we're probably going to talk about the most in this class, we have to take into account that there are three types of cultures that we are looking at: the patients, providers, such as yourself or anybody that is working in your practice setting or under your supervision, including potentially a paraprofessional, a student, practicum or internship or postdoc that may be, working under you and under your supervision, or the person that supervises you, for that matter, as well as the medical culture in which the care is given. And you know as well as I do that the medical culture of is not the same everywhere you go, whether you work in a large practice setting, group practice, for example, whether you work in a hospital or, some sort of medical center, or, community mental health center versus, a prison or a VA, or other government organization. Those cultures are going to be different, and they do affect, the interactions between the provider and the patient, and they do have a tendency to affect the to some degree at least, the potential outcome of the therapeutic relationship. Um, so again, consider the additional layers, so not just the three. If you're providing supervised care, if you yourself are being supervised when you do your practicum, or your your clinicals, or when you're providing supervision for somebody else. And also, especially in this day and age, consider state laws and potentially at some point, even federal laws that address practice limits. Yeah, key point, in I'm an APA side visitor for internship and fellowships or postdoctoral fellowship programs. And in the process of doing the site visit for accreditation of internship programs and fellowship programs, we have to take into account the limitations that a program may have with regards to addressing issues of diversity, equity, and inclusion based on state law. It's not something that we had to think about 10 years ago, 15 years ago. It may not have been something that we thought about too carefully 20 to 25 years ago, just because we weren't there yet. But now it's something that we have to keep in mind because things have changed. And there may be other practice limits. There are laws that affect, that are local laws that affect the kind of therapies you may be able to give, or that, potentially may not be suitable, like gender changing therapies. Um, or things like whether or not you can ask patients whether they have weapons at home. So again, those are just some examples to, highlight the fact that there are definitely additional layers of culture that affect our therapeutic environments and affect potentially could affect the patient in a either positive or, potentially a negative way, depending on what we're talking about. Okay, this may be a good time to take our first break as I realize my throat is getting a little bit dry. So whether or not you choose to take a break when you watch the recorded section, I am going to take a break. So I'm going to pause the recording for just uh, 10 minutes. All right. All right. And I am back from my short break. And we're on slide 35, moving on to slide 36. Okay. So some things to keep in mind with regards to culture and the potential effects that you could see in in your practice. Things like the incidence and prevalence of medical and mental disorders among different groups, help-seeking patterns we've already, briefly mentioned before. We're going to talk about in depth cultural differences in symptom expression, and also in the perception and the understanding of patients' illnesses. That excuse me, touches onto culturally relevant assessment, diagnosis and treatment, which I'm jumping ahead. But we're also, obviously, there are impacts on genetic predispositions resulting in differences in drug metabolism and clearance, psychosocial factors associated with drug effects and response, including things like partner, family, and others' expectations of treatment and acceptance of treatment, or something that we need to, consider, and so on. So if I mean, obviously it's important, it's important to understand why we need to talk about this and how, talking about cultural competence is different now from what it was, 20, 30, 40 years ago. As we know, and this has been steadily creeping up on us, as one way to put it, or maybe just steadily more relevant. Uh, the United States demographics are rapidly changing based on several factors, including the low birth rate of European population, mostly white population, lower mean ages and increasing birth rates in non-European minority groups, so more proportionally more young people are of either minority or mixed background, as well as increasing immigration from Latin America, Asia, and Africa. So whereas I'm going to give you a lot of graphs and a lot of slides, and I want you to keep in mind that none of this is going to be relevant as far as our exam is concerned. This is just for general knowledge, and what is relevant to our exam, I will let you know. So you don't need to worry too much unless I foot stomp a specific issue or specific number that I think it's important for you to know. Just like I said, this trend has been happening for the last, almost half a century. You could see, the variability in different groups in terms of census numbers. Um, changes between 1980 being the green bar in 1990. So slight decrease from 83.1% to 80.3% in the white population, slight increases in the other groups, uh, except for Asian and Pacific Islander, which, it's still a small group, but they nearly doubled in the percentage of the population during that decade. Now, I think it's important when we talk about census, because I'm going to talk about the census and shared data that is based on the Census Bureau, that there are many flaws, with the system. That is to say, the definition of what is white and what is any of the other groups, or even the ability to people to endorse being part of a specific group, has also changed over the decades. So, 40, 50 years ago, you might not have been able to endorse the other category. Certainly, you weren't able to endorse the mixed, diversity or mixed, quote unquote, racial category. And the reason for the quotes for racial is because of what I said before. Race, relates to a genetic or physical construct, and therefore, we need to, it's not something that we can sort of know by looking at a person. So the data is problematic from the perspective of what is even available or what is even possible for people to endorse, in those questionnaires. So we jump to the 2000 census, and the total population of the US at this time includes 281,000 million people, the majority of which are white, described as non-Latina white. You could see that was a big change. That was a big jump, between 1990, where the you know, proportion of the population that was white was 80%. Now we're down to 70%, 69% of the population being white, and other groups holding, um, some groups holding steady, and some groups, just barely identified, including Latinos, which at that time were 12.5% of the population. Just for clarification, in the 2000 census, including people who reported some other race, so really other, and or people who included two or more races. So once again, we're not really even separating people who endorse having a multi-racial or a multi-ethnic background. Slide 40. Once again, this should be 39, so apologies for that. I thought I looked at that over and over again. Jump another decade to 2010. Again, the percentage of whites in the population continues to drop, even though the population as a whole has increased by good numbers, 64% compared to 69% in 2000. And again, most impressively, compared to 82% in 1980. And we have a few other changes in the census, in that now we are able to see people self-endorse as having two or more races or being multiracial. We have a significant increase, what I would consider a significant increase in the numbers of people of Asian background, and an even more significant increase in the number of people with Latino or Hispanic background. And as we know, there are geographical regions where there are regional differences in ethnicity. So this is between 2010, 2011, where the majority of people of color resided in the United States. So, when we talk about local, this is important to know, because whether you practice in California or Montana, your practice is going to be very, very different. Very different. Again, this is back to 2010, but some of these really haven't changed that much. Look at all the states that have less than 14 states that have less than 20% of the population being people of color, including the very Northeast and Midwest. some areas in the Midwest, versus older people in the South and Southwest and West of the country, where more than 50% of the population describe themselves as majority non-white. Okay. And just for context, let's talk about, and I'll get to the 2020 census in a minute, so don't think that I'm ignoring it. I just wanted to share some, there's more information that's available still, even though it's now 2025, about the 2010 census that I can share with you. And even though it likely changed from the previous census, it didn't, it's just important to give you an idea. So just keep that in mind. Um, so, in 2010, this is or 2011, this is the percentage of people from different ethnic backgrounds by work status and by income. So look at the family income below poverty, and you will see those change. You will see where this matters, right? 39% of American Indian, 36% of Black or African American, 33% of Hispanic, 18% of Asian versus 14% of whites, fall below the poverty level in 2011. A big difference also in the number of people in the family, or the number of families where you have a full-time worker, and where you have blue collar workers. So, people in the service industries, people who may have differential insurance and healthcare access availability based on their work status. So, 80% of whites have a full-time worker in the family versus 61% of American Indian. And I just want to emphasize that doesn't necessarily mean that we're not looking at people with multiple jobs. And then, again, the proportion of people of color who are blue collar workers versus white population. So in 2010, this was the projection with regards to the population in 2050. We still have 25 years to go. And it does seem like we're trending according to predictions. So whereas 65% of the population was white in 2010, it is projected that less than 50%, so about 46%, perhaps even less, will be or self-described as white in 2050. Whereas the largest growing population is the Hispanic population. There are also significant changes associated with the Asian population, which again, it looks like it would nearly double again comparatively, as well as the quote unquote other, populations, other including that mixed race and people that that endorse having a different background. Okay, so this was in numbers, so not a visual. The results of the 2020 census, population grew from, what was it before 2010? It's 308, I believe. Yeah, 309 almost. So in 2020, grew to 331.5 million people. This is the median household income, people, with bachelor's degrees, employment rate, and a significant number that, we're going to talk about later on, people without healthcare coverage, was only roughly about 9%. And the Hispanic population grew to 62 million. I don't know if we have it in numbers, what it was in 2010. Or just, no, I don't think we have it. We just have the percentage, and I'm not risking doing the math in public. So 16% of 3.8 or 3.9 million versus now about 62 million. Okay, so this is where we're going to do a little bit of an interactive discussion. to talk about how things have changed. So I couldn't really cut and paste graphics from the census before. So let me make sure. Um, hold on 1 second. I'm going to stop sharing. So I know that I'm accessing the right thing. Yep. Okay. Now share again. Okay. We might need to expand what I'm sharing. You can follow the link if of your own as well. I'm sorry I can't make the sharing screen bigger. Oh, I guess I can. Okay. So what you'll see is you can use this tool to figure out how our population has changed, excuse me, between 2000, 2010, and 2020. So let's look at the total population for now. And if you follow the graph, you'll be able to see how our population has changed in terms of age, right? So this was 2020. Majority of population being people that are between 55 and 59 years old. Those are, our um, start to be our boomers and our elderly, at least I'm not saying 55 is elderly, but coming into retirement age. Look at 2010, just briefly. Thought I changed it. Yeah, and it did change. And you could see we had the majority of population was between the ages of 45 to 49. So certainly increasingly, we're getting it to be an increasingly older society, but that's the total population. We're going to see the difference when we look at different ethnic groups. And then in 2000, the majority of our population was middle age, 35 to 39 and 40 to 44. So again, this is a really good representation of our aging population. Um, Something else that we're going to see if we compare 2000 to 2020 is how the numbers are changing, especially in certain ethnic groups with regard to people under 18. We won't look at it just now, but just keep that in mind. So let's look at um, any other group. I'm going to look at American Indian and Alaska Native, just as a comparison. So population used to be 2.5 million. Most of the population was younger. Again, you could see minority populations tend to be younger. We do have, quite a few numbers in the middle age, not as many uh, as we get older, of course. 2010, here's the growth in the population. Median age is 30. The percentage of the population under 18 is about 30%. And so you could see this as a younger population, right? The majority of the population, 15 to 19, proportionally, a good third of the population is under the age of 18. And then in 2020, median age a little bit older, 33.1, but still, significant number of young folks. So that's just to give you an idea. There's other ways to look at this data. Let's look at Black of African American, just for the same thing. Again, majority of the population younger. Median age is 35.1. Or 2010, same. good number of people who were, between the ages of 15 to 19. Likewise in 2010. So again, there's a lot of ways you could look at this data. See, you could look at states, metro areas, micro areas, and specifically counties. You could see for yourselves all the options that you have to kind of break this down. But what I'm trying to show is the idea that, let's just look at, for example, the total population median age is 35. If we look at people of Hispanic background, which it's say Hispanic or Latino, median age is 25. Well, that's in 2000. So let's look at it. It's 30 in the 2020 for Hispanic and Latino, 38.8 in the total population. So again, as a general rule, you're going to find that the minority populations, minority groups in general are younger. And those, those population changes are going to be uh, pervasive, or are going to be part of our reality. Pervasive is not the right word, but they're going to be a part of our reality for a while. Okay, I'm going to stop sharing so I can switch over to the slides again. And that means my screen is going to be a little bit off until I get it figured out. Okay, here we go. Okay, so why is this important? Why is any of this is important when it comes to, understanding those facts and figures? Again, there's nothing that I need you to memorize. There's really nothing important that I need you to know, other than the fact that the projected seems to be coming true in terms of, the majority of the population being minority or of minority backgrounds in 2050 compared to 2010 or the 2000s, whenever that figure 2010, whenever this projection on slide 43 was developed. But the reason we care about this is because there's evidence of racial and ethnic disparities in healthcare. I mean, we know this, right? We saw it during COVID. It was kind of in our faces, even though I think for some people, some of us, this has been common knowledge for some time. It really was in everybody's face during the pandemic, as we noticed how difficult, how different, healthcare became for some groups versus others. The availability of testing, the availability of therapeutics, that sort of thing, and even the mortality rates. Um, and this is true of, across medicine in general, certainly true of psychiatry specifically. And so what are some of the implications of that? So for example, providers may miss screening because they are unfamiliar with the prevalence of a condition among a racial or ethnic group. So if you don't know that Asians from Han descent or Chinese Americans from Han descent may have a potential problem with the use of carbamazepine, then you may miss some important screening that may lead to potentially not just intolerable, but potentially lethal, consequences. They also may fail to consider differential responses to medications. And this is true again across medicine, not just in psychiatry. So providers may order fewer diagnostic tests for patients of different cultural backgrounds because they may not understand or believe the patient's descriptions of symptoms. We're going to talk about the over-reliance of chronic pain and other common, illnesses, physical illnesses for patients who have of a minority background when it comes to, presentation of psychiatric disorders. And even though they may be comorbid to real physical, not real is not the right word, but evidenced physical complaints, they may be disregarded by providers. Um, just say, oh, they're just making it up, or it's in their head, or that's just depression, as opposed to, evaluating for a for a medical comorbidity. Um, in turn, providers may order more diagnostic tests to compensate for the fact that they may not understand, they may have language barriers, and they may increase the cost and potentially to some detriment to the patient, the availability of services for people who are culturally different. Um, it may be that we overlook the potential interaction between prescriptions, as in pharmacotherapeutics, and traditional remedies because we don't even ask. Or maybe we overlook it, or maybe we don't know enough about those things to even know that there is a potential interaction. Miscommunication or and that's not just miscommunication, but different styles of communication. We're going to talk about that. May lead to faulty diagnosis. So for example, a patient who may be talking about talking to their dead relatives, maybe misunderstood as being psychotic, as opposed to understanding from a cultural perspective that that may be entirely appropriate, and in fact welcomed and part of the grieving process, a positive part of the grieving process in certain cultures. Um, Miscommunication may lead to unnecessary lab testing, as I mentioned before, medication-related errors, so for example, if we don't take into account, side effects or complaints that the patient may be expressing, decreased treatment adherence, missed opportunities for early detection and prevention. So just kind of keep that in mind. So for example, did you know that providers are more likely to prescribe older medications? You should know that, I'm sure you do. Older medications for more serious mental illnesses to minority groups. So we're talking about, for example, the first generation psychotropics being prescribed to minority groups, despite the availability of second generation antipsychotics. Or the TCAs being prescribed to minority groups, despite the availability of SSRIs and newer antidepressant medications. And not only that, but being prescribed for the wrong condition. So, or for non-FDA approved conditions. So for example, the prescription of antipsychotics for depression, or for, behavioral management of, things like ADHD or something along those lines. And here's an example of that. In 2009, the New York Times published this report by reporter Duff Wilson, where they found that in a Rutgers Columbia study, uh, children covered by Medicaid were given more powerful antipsychotic medicines at a rate 4 times higher than children whose parents had private insurance. Just think about that. That is staggering. 4 times higher. And as you know, Medicaid is a federally funded program, sometimes with state sponsorship, for children who are underprivileged. So this is for economically disadvantaged group. Medicaid is only given to people who have, mostly given to people who have economic uh, disadvantages or economic limitations, and or are permanently or physically disabled. Um, and also Medicaid children were more likely to receive the drugs for less severe conditions than their middle class counterparts. This is what I was saying before. For example, antipsychotics for management of behavioral problems like ADHD or oppositional defiant disorder. And what the article explores, some possible reasons. So, it's just, you may have some thoughts of your own about whether or not this applies, or what you've seen, based on what you've seen in your practice, or, in the settings in which you work, or, even in your community, whether or not this could happen because Medicaid doesn't cover therapy the way they cover medications. So whereas some things that could be managed with behavioral interventions in, middle class, or, kids whose parents have private insurance, um, they would be less likely to rely on behavioral interventions, less likely to have access to behavioral interventions, and therefore those strong medications may be an acceptable, quote unquote, um, alternative. Um, it also means that families who meet the poverty guidelines or economic guidelines for Medicaid have trouble consistently attending therapy sessions. So even when Medicaid does pay for behavioral interventions, families may have less able to participate, either because of work or schedules, conflicts, or transportation, you name it. And it may be because we have separate and unequal sources of care, primary care versus psychiatry, resulting in unmet patient needs. So it may be that children who are covered by Medicaid, may be more likely to rely on a PCP or a primary care manager as opposed to a child psychiatrist, for example, in order to meet their psychiatric care needs. It also may be the result of provider misdiagnosis or bias, or willingness to use drugs off-label. An example I gave before, it's using antipsychotics for ADHD or behavioral problems. Something that, would not be, and that the risk and benefit ratio, or, yeah, uh, decision-making protocol may be different, for a kid whose parents are um, involved, and available and consistent, with therapy and behavioral interventions, versus, parents who cannot afford, to be as involved, because, they work, or they have other responsibilities and other stressors to deal with. It may also be because minority status may result in greater stresses, and therefore differential patterns of mental illness, although this has not panned out. So the fact that minority status does result in greater stress, yes, that part has panned out. Differential rates of mental illnesses, not so much. So just um, want to make sure to clarify that. Okay. So this would be the time, normally in live lecture, when I would start introducing some poll questions. Since we won't have the opportunity to do those in the recorded lectures, I will have more poll questions in the live lecture. And the goal of the poll questions is essentially, I present a multiple choice question. I'll give you the opportunity to give me your answer based on material that we have already covered, or material that should be pretty familiar to you. And we're going to see how everybody responded and give you some feedback as a group. Keep in mind that those may be practice questions for your quizzes, maybe practice questions for your exam, or at the very least, they're going to be in the same style as exam and quiz questions. So the poll questions are important. A good way to review what you're learning as you're learning it. A good way to see whether you're, keeping up and paying attention. But also, a great way to foot stomp, important information that may be helpful to you, again, in some of those exams. Okay. So when we talk about disparities, and that's what we're talking about really, access to care is the first issue. So, this slide talks about separate and unequal sources of care, and that's what we're going to focus on next, right? What that translates into in terms of health disparities. So at the moment, because we're skipping the poll question slide, we're going to jump to slide 53, and which is a topic. Um, and just as a definition, which you're not responsible for, but I just want to give you a definition of health disparities according to the Healthy People 2020 project. Health disparity is a particular type of health difference that is closely linked with social or economic disadvantage. So just want to make sure we know what we're talking about. So health disparities typically adversely affect groups of people who have systematically experienced greater social or economic obstacles, thus under underrepresented, underserved, marginalized, all those terms, apply. And in most cases, those obstacles, besides the economic obstacles, those social obstacles may be racial or ethnic, identity, religion, sex, gender, minority status, uh, degree of mental illness, including, the chronically and severe mental illness, cognitive disabilities, or as well as, sensory or physical disabilities. And of course, as we talked about, geographic locations. So, the availability of, I would have to guess that the ability of very culturally sensitive or centered services in, one of the 14 states in which, less than 20% of the population belongs to a minority group, may be less than stellar, maybe great, for all we know, but it may be less than great compared to a place where, that is 50% or more of the population are come from a minority background. Okay, so when it comes to health disparities, and like I said, access to care is the first step, and access is usually derived by health insurance coverage. So, I'm going to talk about pre and post the Healthcare Affordability Act, or the ACA. I always have trouble with the acronym, but you all would recognize it as Obamacare. Um, so just as a way of comparison, look at the uninsured rates in 2002. So this would be pre-ACA. Where white, the only 13% of whites were uninsured. 34% of Latinos, 29% of American Indian and Alaska Natives fell in the uninsured category. So as a whole, I want to say that maybe 20+% of the population were uninsured. This doesn't tell me. But in terms of by group, there are significant differences in uninsured status. And also, just as importantly, based on the report that I share with you from the Rogers Columbia study, the Medicaid or other public insurance rates also significant different. Here we go, 28% is the largest group of Medicaid and other publicly funded um, insurance in the American Native population, or American Indian, Alaska Native, but only 10%, if I'm looking at that correctly, in the white. So most whites were covered by private insurance, otherwise, or employer purchase, employer funded, or co-funded insurance, compared to only 41% of American Indian, only 42% of Latinos. And you could see the other numbers for yourselves. This is this is after, somewhat after the ACA. The full power of the ACA had not been realized quite yet. But you could see the numbers of uninsured changed drastically in some groups. So not so much in whites. Again, 13% before, 13% after. 71% versus 72% had employer or other private insurance, so that didn't change very much. But there was a significant change in the underinsured or uninsured in other groups. Probably, like you see, American Indian, Alaska Native, and Hispanic still trailing the rest of the other groups, and relying quite a bit on Medicaid and other public sources of insurance. But as well, as well as the African American population. But again, the dream was not realized equally for all the groups, even though there was a significant number of people who gained insurance and therefore gained access to healthcare as a result of the ACA. Affordable Care Act. I knew I had it, the abbreviation, the acronym, written somewhere, because it's always something that that I struggle with. Okay, so this is a comparison chart with regards to uninsured of in children and adults. So I was talking about children before, so this is important to highlight. Again, just in general, more children who fall in the category of Medicaid and other public insurance in minority children compared to white children, um, and more children who are uninsured as well. Um, okay. Um, this is just a population of uninsured. So this is not, and again, I don't have it in any of these charts what the percentage of uninsured was for the total population. But again, just as looking at the uninsured only, even though it says that 45% of the uninsured, so almost half of the uninsured were white, again, just by um, proportionally, um, given they were the largest numbers in the population, um, a lesser proportion of whites were uninsured at that time. Um, okay, this is just kind of uh, same numbers that we've seen before. But this was in 2014. So this is a more, increase adoption of some of the ACA rules, including um, some of the requirements for individual insurance, the marketplace, et cetera, et cetera. And so you could see numbers of uninsured in general are decreasing. Um, this is uninsured by race in 2014. Again, you could see numbers are slightly changing. So if you look at slide 57, 32% of Hispanics, 15% of Blacks in 2011, 24, in 2014, 34% of Hispanics, 14% of Blacks. So not a great deal of change, slightly increasing kind of at a slow pace, a snail pace for insurance. And this is a representation of the changes in the last decade. So 2013 to 2023, roughly the last decade. So definitely post ACA. Total uninsured in 2013 was 13.3. Total uninsured in 2023 was 8%. So the continued decrease in changes in and you could see a line here in between 2019, end of 2019 and into 2020 for the recession. Um, the slight increase in the number of people who fell out of insurance, probably because of employment, um, but not a great deal of change overall. However, when we look at the same data, so let's look at the same data for each of the minority groups that have been listed in previous graphs. And this is from the Kaiser Family Foundation, by the way. That's the KFF abbreviation at the bottom. So, this is publicly available information. So if you look from 2010 to 2021, again, another decade where we had you could see in 2014 was the ACA implementation of Medicaid expansion and state-funded Medicaid expansion and marketplace with federal funds or federal contributions, as well as marketplace expansions and what that meant in terms of continued drop in the number of uninsured. And there's a marker here for the start of the COVID-19 pandemic and where we stood there. But again, if you look at the numbers comparatively, the number of uninsured whites has been lower than all the rest of the other groups and has remained lower, except for, I believe those may be Asian, which are now at 6%, versus 17% in 2020. 2010. Um, for everybody else, although the rates have dropped, they have continued to be higher in general. So, here's a good example. The Latino population, I think Hispanic population is the darker blue up here, 33% were uninsured in 2010, 19% in 2021. So um, uh, definitely, if you look at Medicaid expansion, if you look at the ACA, what you should see, and this is not a, you know, um, political argument in any way, shape, or form, or it's not intended to be so. It's just a reality in numbers. The people who were most who benefited the most from the changes in healthcare policy were people of minority backgrounds. Okay, so and this tells you what I just said. Basically, geography matters, policies matter. So in the states that adopted the Medicaid expansion versus non-expansion states, the proportion of people who maintain who uh, this is a percentage change in uninsured rates in comparison. So not a great deal of difference for, Asian Americans, maybe not such a significant difference for whites or blacks, but potentially a good deal of difference for Hispanics, a good deal of difference for American Indian and Alaska Natives, and a good deal of difference for people of Alaskan and Pacific Islander background. And this is just another way to look at, kind of what I just said before. Again, a comparison of expansion states. This is so the previous slide, 62, is between 2010 and 2018. So that's more data. This is a more recent graph between 22 to 22 and 23. So you're going to see a slider, less drastic or less dramatic changes. But you could see a significant difference and the number of people who remain uninsured, especially those below the poverty level, and the total and non-expansion in uninsured rates in the non-expansion states compared to the expansion states. So in slide 64, once again, just looking at it from a geography perspective. So this is just to help you identify based on the area of the country where you work, whether there's going to be, people, a great deal more people who may be likely to, maybe less likely to afford your services or may have more difficulty getting access to services, such as, in Florida, Georgia, Mississippi, Oklahoma, or Texas, where 12% or more of the population are uninsured, versus some of the places, for example, in the Midwest, Minnesota, and I think that's Iowa. Yep, where, only less than 5% of the population are uninsured. And this is just one example, in terms of one group. So I didn't do this for every single group. I just wanted to give you one example of the information that is available, what you can look at. The share of total non-elderly population that is Black. So and Medicaid expansion status. So the starred states are states that have not adopted Medicaid expansion. There are also states that have more than 50. They happen to be states where there are more Blacks in the population. So the entire South, for the most part, with very few exceptions, as well as some of the Midwest. Well, I guess you'd consider Texas the South. Um, but some of the other states, again, that are starred are states that have not adopted the Medicaid expansion. But as you could see, a good deal of those include populations or places where the population of Blacks or African Americans is greater than 15%. We're getting there, I promise. Um, Yeah, I'm not gonna talk about this. You can review this on your own 66 if you like. Um, and this is another data that covers children, specifically the change between 2017 and 2018. So it's not going to give you a great deal of information again because it's not, you don't have a decade to compare. But it does give you some information about, income characteristics of uninsured children, and race, ethnic characteristics of uninsured children. So just FYI, and again, pick your state or your region, and pay attention specifically to those areas that affect you the most. Okay, just one more slide, and then we're gonna take our next break. Or basically jump into the next topic. So, as I said, this is our Kaiser Family Foundation uh, data that I've shared with you. Some of the slides are from the Census Bureau, so there's a mixed bag in there. And what they reflect on in their report is that people of color, because of their lack of access to private insurance, again, employer paid or employer contributed for the most part, or even self purchase, people of color may be more likely to be uninsured. We just saw that across the board, and that continues to be the case even with the ACA. The ACA coverage expansions increase coverage for people of color. I said that before. There's been some significant benefit for the population as a whole. There's been even more or even greater benefit comparatively or proportionally to populations of color. And thus, this is an area that is thought, at least by the Kaiser Family Foundation, to have an impact on reducing health disparities. Reducing, not eliminating. Just want to make sure to point that out. Um, and as I mentioned, and could definitely be highlighted by by this graph specifically, people of color have a higher stake in state decisions to implement the ACA Medicaid expansion. So for what it's worth, um, think about those states that have not expanded Medicaid. Think about the policies and the representation of people of color at local and state levels where those decisions about Medicaid expansion are made, and understand how they may have less of a voice, but definitely a higher stake because they are the ones that are likely to benefit the most by those policies. Okay, I'll leave it at that. Um, we're going to jump into slide 69, which is the start of talking about cultural competence. But before that, I am ready for my next 10-minute break. So I'll stop sharing and pause the recording for 10 minutes. All right, on to the next segment, which will be the last we cover before so for the morning segment before the afternoon break. Okay, so we're going to talk about different aspects of cultural competence next, and I'm on slide 69 for those of you who are following. Um, so, moving on. Some important terms to understand and to try to tease out as we did with race, ethnicity, and culture. We want to make sure that we understand the different aspects of cultural competence and what they relate to. So here are some definitions. Cultural sensitivity uh, means a willingness to explore the areas and learn from patients and their family and their beliefs. So it's essentially knowing that differences exist and wanting to learn about them without stereotyping. And I've already mentioned it is difficult to not stereotype. We're going to stereotype in this class, I guarantee you. And I apologize in advance for anybody who may be offended by that. But ideally, the goal is to avoid stereotyping or to, recognize biases and stereotypes and, try to delve into that. Cultural knowledge um, talks about basic anthropological information. Sorry, Siri's decided to talk to me. Um, Relates to basic anthropological information, including epidemiology, illness behaviors, culture-related syndromes, which is going to be a good amount of what we talk about tomorrow, or, the second, not tomorrow, the second day. I'm so used to this class running on a weekend, the full weekend, Saturday and Sunday. So day two, to make it clear, not tomorrow. Um, and it's a good chunk of what we're going to talk about: epidemiology, illness behaviors, and cultural related syndromes. So just keeping in mind that cultural knowledge involves, besides books, articles, the use of consultation with experts on a particular group or a particular cultural system, and also, potentially on patient and family or friends of the same ethnic cultural background. Um, Cultural empathy relates to the ability to feel and understand the patient's cultural perspective. So that means asking questions. How do we, how can we understand the person's cultural perspective without learning about them? So, it's really important that as part of our biopsychosocial assessment, but also as part of our ongoing therapeutic relationship with the patient, that we don't stop asking questions. We don't stop being curious, and we don't stop allowing a safe space in a therapeutic environment in which people can discuss conflicts that they have, because of their beliefs or their behaviors, or because of, differences in, you know, um, generational differences, for example, with their parents or their grandparents, or, their extended family, as a result of cultural practices and behaviors. So just keep that in mind. I mean, the term that has gained a lot of understanding, or a lot of, focus, or, emphasis in the recent past, is the uh, concept of cultural humility, which was defined by Hook et al. And as the ability to maintain an interpersonal stance that is other-oriented or open to the other in relation to aspects of cultural identity that are most important to the person, the individual. And that other orientation, I would, emphasize, is that encompasses that curiosity, and that humble approach, again, humility approach to understanding that the individual is the expert of their own experience, and that as much as we may have culturally relevant knowledge, something we talked about in the previous slide, uh, we may not be able to understand everything from the patient's perspective without understanding what their perception of their culture, and the benefits and the drawbacks, or the potential conflicts that they experience as a result of that. So there are three related concepts associated with the cultural humility. And this is kind of an older um, um, concept, but I think it still applies very well. And that is the idea that cultural humility encompasses a lifelong commitment to self-evaluation and self-critique. Kind of going back to what I said before, we're not once and done. You could be an expert in a specific group or a specific population. That doesn't mean you know everything, because the knowledge that we have is never finished. We're never, again, done, one and done. We don't arrive at a point where we are done learning, and every individual's experience is going to be different. Also, cultural humility includes the desire to fix power imbalances, and that includes those healthcare disparities that I was talking about before, or that I spent a great deal of time talking about before, where there ought to not be power imbalances. Our goal is to fix them. So recognizing that each person brings something different to the table, both patient and provider, as well as maybe the patient's family, the patient's contextual circle of influence, and that we need to see the value of each person for what they, contribute to our understanding of their problems, and most importantly, how to treat them. And also, it includes the concept of aspiring to develop partnerships with people and groups who advocate for others. So we psychologists should be advocates for social change, advocates to fix those power imbalances, and advocates to create communities that are providing that are removing barriers so that we can have profound impact on systems, as I was talking about on the healthcare culture, for example, that we particularly have an impact on. Okay. As part of this cultural competence, is important to understand that we're going to be aware and knowledgeable about culturally relevant interactions. And that includes the ability to detect and manage transference and countertransfers, transference based on differences in background. So, one important difference, for example, could be language style or even language barriers. Somebody who speaks with an accent, somebody who doesn't speak English either as their first language, and therefore may have halted speech, or take more time to develop their sentence construction. It may take more time to get the word and the meaning of their words out, and that may be something that some of us may have some difficulty with, may have maybe something that kind of grates on our communication style, or that we at least have to be consciously aware of, so that we don't grade on their communication style by interrupting, by finishing their sentences, by trying to guess what they're going to tell us, and limit our communication to closed versus open questions, in order to minimize those things. So, just something to be aware of. And the other thing to be aware of and understand and be knowledgeable about is culturally relevant therapies. In that and considering that the most effective interventions consider the role of cultural impact on illness, or cultural factors on illness presentation, illness definition, illness perception, treatment expectations, and expectations of the provider and the patient. And again, I use the example, do you hear voices? I've already mentioned, the example of someone who, potentially hears the voices of their loved ones after they passed on, or believes that the dead communicate with the living, and that's a form of, helping to manage the grief, or helping the other person transition, the deceased person transition to the afterlife, or maintaining the spiritual connection with the living, or so on and so forth. So that's those are really important cultural factors, as well as culturally sanctioned coping mechanisms that need to be reinforced and or potentially confronted. We talked about traditional healers, understanding the role of traditional healers in treatment. What about, potential cultural sanction coping mechanisms that may not be so useful? And how do we confront those? How do we talk about them? That sort of thing. And a term that we need to understand is what used to be in the DSM-4 described as a culturally bound syndrome, and in DSM-5 described now as a culture-related syndrome. And the change in language does mean something. It means that we are understanding that those syndromes are not exclusively the domain of one specific group, or the experience of one specific group, but that they can translate into other groups' experiences, but they may be related or have some cultural factors that may be related with the manifestation of symptoms. So basically these are culturally based signs and symptoms of a mental distress, or even maladaptive behavior that are prominent in folk belief and practice. And we're going to show you some examples of that. Keep in mind that while DSM-4, this is another difference, while DSM-4 used to have a specific um, what's the word, section for culturally bound syndromes, like ataque de nervios, for example. That's not the case anymore. You could see that the American Psychiatric Association, in their release of DSM-5, decided that the fifth edition, or that in this edition, is instead of a simple list of cultural-based syndromes, the DSM criteria for every syndrome is going to include cultural variations in the presentations, and give some more detailed information about cultural concepts of distress. So I'm reaching out, just so you guys know, reaching back for my DSM, right? You guys know what it looks like. Before, again, we would find in any segment of or specific segment of the diagnostic criteria for culturally bound syndromes. And said, I just opened to the schizophrenia spectrum and other psychotic disorders. And what you'll find is that along with diagnostic features, associated features, prevalence, development and course, risk, and prognostic factors, you're going to have a section in every diagnostic criteria that says culture-related diagnostic issues. And you will find that across the range of disorders, pretty much in any of the categories. So if you haven't had an opportunity to look at DSM-5's, and this is a TR that I'm using right now, cultural related diagnostic issues associated with some of the most common diagnoses that you see in your clinical practice, I challenge you to take a look at them, because it might be interesting reading. Some of them are very short, some of them may be more expansive, but they're definitely interesting. And also, as you could see highlighted, the DSM now includes a clinical interview tool to facilitate comprehensive person-centered assessments. And that clinical tool, again, something you can look at for yourself in your own copy of DSM, if you use the DSM, as something that you could potentially use, because it does integrate questions and assessment of things like cultural factors. So I think so far we have a pretty good understanding that culture impacts the understanding of the illness, not just in the provider, but in the patient, how they perceive their illness, both originated, is maintained, and whether or not is an illness to begin with, it's a problem or not a problem, and how it should be managed. The perception and the presentation of symptoms, the reaction and adjustment to the illness, again, good thing, not so great thing. The expectations of the provider, some cultures are still pretty much adhering to a paternalistic expectation of the relationship between doctor and patient. And so they may have an expectation of the provider to be more directive, to, be more to basically dictate what the treatment plan is going to include, both in psychotherapy, but potentially even more in the pharmacotherapy. And so you have to be able to understand that and manage that, versus having a more collaborative relationship. The desired and expectation for treatment, the motivation for treatment, the adherence to the treatment plan, and variations to the treatment plan. And notice that I use the word adherence. Hopefully you do as well. Versus compliance. Compliance does denote a paternalistic belief that you write orders and the patient complies with the orders, versus adhering to a treatment plan that has been mutually discussed and mutually agreed upon. And culture impacts the clinician diagnosis and choice of treatment. Again, please, keep in mind that by culture, I mean not just the patient's culture, but also the the provider's culture and the culture of the medical setting in which they practice. So this is slide 76. Um, so here are some examples of where cultural competence can really be helpful, in helping, in helping us understand, some of these things that I mentioned in slide 76. The old order Amish community and the presentation of bipolar symptoms. So we do know that bipolar disorder is pretty much has pretty much the same prevalence across all populations. It's not different in the old order Amish community. But what we do know is that they view it as a medical condition um, that is in the blood. So, pretty much a biological conceptualization of the disease. And they seek medical care for the disease because they feel that mental illness, such as bipolar specifically, interferes with a person's relationship with God. So this is, just one way to look at illness that is, potentially a little bit different than what you might see, in other groups. Chinese people or people of Chinese descent have a conceptualization of depression and neurasthenia, which is basically, depression, um, as a condition that is characterized by both physical and mental fatigue. And you know that DSM includes physical symptoms, right? Lack of energy, lack of appetite, lack of sexual interest are symptoms of depression. So we do understand that there is there is a mind and body connection, right? In Western style, diagnostic and conceptualization patterns. However, for the Chinese, things like mental fatigue, dizziness, headaches, other pains, and as well as concentration, sleep disturbance, and memory loss are part of the, depression presentation. So they're not separate, they're part of the same condition. And then, of course, as I mentioned before, there are culture-related or specific syndromes, again, not culturally bound, but culturally related syndromes that, whereas understanding them may help us with the patient and clinical outcome. Now, is it going to be drastically different to treat ataque de nervios versus treating panic disorder or generalized anxiety? Potentially not. But your patients believe that you understand what's going on with them and that you really know where they're coming from is going to it's going to go a long way into helping them not just trust and be trusting of their relationship, but to adhere to the medical plan, to challenge you when they don't feel like the treatment plan is working, or to challenge themselves when they don't feel like they're doing, what they need to be doing to adhere to the treatment plan. So again, it's not, from a pharmacological perspective, it may not be all that different. But it is really important information that's going to help you, solidify that report and that, and potentially lead to better outcomes in the relationship. Okay. Again, this would be about the time when I introduce another poll question. So I'm going to skip from slide 77 to 79. And we're going to start talking about genetics. And this is a heady topic. So we're going to start to talk about genetics, and then we're not going to be done with this topic until after the lunch break. So just want you, or the midday break. So I just want you to understand that there's a lot to talk about, and again, for all intents and purposes, some of this may be a review for you, but some of it may be, stuff that you haven't really seen in other classes. Okay, so in terms of, what I want to talk about is basically I want to emphasize the interaction, how genetic how in transcultural psychopharmacology, the interaction of genetic and environmental factors is key. So there's no one without the other. Genes are not, we're not just a result of our genes. We are not just a result of our environmental influences. Both have to come into play. And there are different ways that I'm going to explain that and hopefully help you see. I'm kind of a visual learner, so I like these graphs and others that you're going to see to kind of bring the point home and really help you understand and really to help you educate your patients because I've seen it, I've done it, and I think it's very helpful for some patients to know that they're not quote unquote predetermined um, just based on their genes. So you see that culture and ethnicity, are the beginning of um, the graph here. Cultural affects environmental factors. And by ethnicity, I think they mean right here on this graph, they are talking about what, in other writings you would consider racial, meaning your genetic makeup. Again, um, I want to emphasize that's not, what a race is not something that we're going to be discussing when it comes to genetics. Um, unless we're talking about the human race. So, but this is where that comes from. And the interaction of culture and ethnicity, the interaction of environmental and genetic factors affects both the pharmacokinetics and the pharmacodynamics. And both of those, as you know, are going to affect the dosage and the side effects, as well as the clinical response to drugs. So really simple. We've seen this before. You've talked about it in other classes. But this is just a way to bring it home. And this is another way. I really love this graph. This is another way to bring home the point that, there's your genetic constitution. So again, genes are not the sole predetermined factor of how we behave, both, physically and medically, but also, in our mood and actions. But there's a lot of other factors that have a bidirectional relationship, and I want you to take a look at how many of these are not just environmentally related, but maybe uniquely important to certain populations, and specifically the populations that we're talking about, the population of people of color, who tend to be not all of them, but who tend to be more likely to have come from marginalized communities, of have, environmental exposures, of have, lower socioeconomic status, things like exercise, things like tobacco or marijuana smoking, alcohol intake, starvation, stress. We talked about cultural stress or minority stress, things like dietary factors, drugs, psychological status. Um, this is psychological, not psychologic. Well, actually both. Occupational exposures. Again, think about the blue collar workers versus, people who are white collar, and what occupational exposures they may be more more, prone to. Infection, disease, sunlight, those sorts of things. So I really like this graph again as a way to remember, all of these things, including cardiovascular function, liver function, renal function, have a bidirectional relationship between genetic constitution and other exposures. So there are two, in talking about genetics, in this context, we're on slide 82. We are going to be looking at two specific things, pharmacogenetics and pharmacogenomics. So the definition is right there for you. Pharmacogenetics is the use of genetic information for predicting or guiding the way an individual will respond to drugs. If I were to make which I normally do again in a live lecture, if I were to, have people raise their hands if they've, experienced, they have, firsthand or close to firsthand, secondhand potentially, if you're not um, in a shared practice, with patients who have had genetic testing or in group practices or clinical settings in which you work with prescribers who use genetic testing, then that's what it's all about. Pharmacogenetics. It's about using the genetic information of the individual for predicting how they will respond to a drug. And by response, we're going to talk about it shortly. We're talking about both efficacy and safety. Pharmacogenomics is essentially the branch of genetics concerned with the way in which an individual's genetic attributes affects the likely response to therapeutic drugs. So it's kind of the same, not exactly. It's just the field. Um, so yeah, just for what it's worth. Um, So on slide 83, you're going to see an interesting picture that brings about a lot of questions. And again, if this was a live lecture, we'd have the opportunity for some, guesswork and interaction. But I'll present it to you the way that I have presented it to patients and, classes and other students that I precept or teach. And that is this picture of two organisms that you may or may not recognize. I don't know what they're, um, I guess, official name is, but they're water fleas. And what's interesting about this pair of water fleas, which are basically, microscopic, translucent, you could see through organisms that obviously live in water. About this pair, what's interesting about this pair, and is that this is a pair of clones. This two organisms have the same genetic makeup, right? So what you would expect is that if they're genetic clones, that like other clones, they would be identical, but they're not, right? They have what is clearly visibly different features, such as the helmet. In this case, the one on the left has a very pointed helmet, that thing that covers the head, um, whereas the one on the right has a very well-rounded helmet. And then what is called a spear, and just for the sake of the example, so on the one on the left has a very long and sharp spear. The one on the right has a much shorter, much eh, less, potentially um, sharpened or threatening spear. So again, we got two organisms. They're clones, which means they have the same exact genetic makeup, and they look very different. And the reason you might wonder why these organisms are different, the reason is because this one, the one on the left, was reared in water with predators. Okay, pretty self-explanatory, right? Our genetic makeup is affected by our environmental exposure. There's organisms are translucent, they're see-through, they become red when they're under stress. You could see it. It's a visible representation of how, regardless of our genetic makeup, environmental exposures mean that our genes may be expressed differently for different individuals. And that's one way to think about why potentially the field of pharmacogenetics may not be exactly where we would like it to be, where it may be helpful, but it doesn't tell us the complete story because environmental factors are always going to play a part. So as you know, the goal of pharmacogenetics is to individualize medicine by using person-specific or individual-specific information. And I mentioned before that if, the individuality or the focus is going to be on both efficacy and safety. So efficacy refers to the prediction of a positive response to therapy, right? We want to try to um, predict and potentially minimize the cost of medicine in general, not just psychiatry, because this is done with other medical therapies as well, by reducing the trial and error and going right for the agent that is going to have the best outcome, that is going to have the best chance of in treating the disease. Safety is concerned with the influence of genetic variations on drug side effects. So that's the potential for avoiding side effects or avoiding problems that would otherwise present for the individual based on their genetic makeup. So, the goal ideal, again, is to individualize medicine by using person-specific information in order to increase the efficacy of the therapy, in order to increase the safety of the therapy. So both from a practical and economic perspective, this is a good thing. It's a good goal. Let's talk about an example. I've already mentioned it briefly, but this is more formal and something that you definitely should know about, because it's one specific form of pharmacogenetic or application of pharmacogenetics that applies to psychiatry. And that testing by the FDA is recommended for a genotype for people of Asian background, and particularly Han Chinese, as I mentioned before, for this allele, this one over here, if treatment with carbamazepine is considered. And the reason why, we'll talk about it later, but I'm going to tell you right now, is because the people who have this allele, which you can see in a genetic test, are more likely to develop toxic necrolysis, or Stevens-Johnson syndrome, or both. So this is a very important thing for you to know, once again, but also an important example of safety pharmacogenomics. This is something that we would do because the FDA requires it, not just to see if carbamazepine is going to be effective or not even to see if carbamazepine is going to be effective. We do it just to see if carbamazepine is going to be safe for that patient. Okay, this is definitely a review, pharmacokinetics and pharmacodynamics, right? You know the definitions. Pharmacokinetics refers to the actions of the drug in the body over a period of time. So it includes the processes of absorption, distribution, localization in the tissues, biotransformation and excretion, essentially what we already know. And in short, what the body's physiology does to a drug. Pharmacodynamics, on the other hand, refers to what a drug does to the body. So the study of how a drug acts on a living organism, including the pharmacologic response and the duration and the magnitude of the response observed relative to the concentration. So things like area under the curve, and that sort of thing. So basically what the drug does to the body, as opposed to what the body does to the drug. And both of this, may be affected by genetics. So when we look at genetics, some other definitions that are important for us to know are the genotype, or the gene inheritance. So the genotype is basically our genetic or nature. Yes, picture. You know that genetic polymorphisms are variations in specific DNA sequencing, and those genetic polymorphisms can lead to different pharmacokinetics and potentially pharmacodynamics, depending on what we're looking at. They definitely affect drug metabolizing status. Again, that's the pharmacokinetics part. And as I said before, they can affect pharmacodynamics as well. And we'll share some examples of that. On the other hand, the phenotype, which is the gene expression. So the genotype is what the genes look like, basically what you're born with. Kind of, in the example of the cloned water fleas, it would be their DNA sequencing. The phenotype is the expression. So that includes the nurturing part of the equation, the environmental factors part of the equation. In terms of pharmacokinetics, it includes things like induction or the speeding up of metabolism. So, for example, that some drugs and some dietary agents, alcohol, tobacco, for example, are may induce liver enzymes that end up speeding or slowing the metabolism of certain drugs. So induction or inhibition, may be the result of environmental influences. And pharmacodynamics, things like albumin levels and the up and down regulation of receptors. It could be influenced by our phenotype. So again, genetic, that, individualized medicine, the goal may be difficult to attain because of all this variability or factors that introduce variability. So again, just another graph. I like visual ways to, think about these things. There's the genotype, um, and the interaction with the environment, and that's what leads to our phenotype. Okay. And pharmacogenomics, as I mentioned before, is the study of the role um, of the role of inherited and acquired genetic variation in drug response. And here's another example, where the FDA revised the label. And by the way, this allele that we're supposed to test for in people of Asian descent, when we were considering the use of carbamazepine, also required an FDA label change. I think it is a black box warning. Somebody can check me on that if you'd like. But same was true of this label revision for warfarin, as you probably know, is a drug that was commonly used to thin out the blood for people with cardiovascular disease or cardiovascular risk. There are newer drugs in the market that are used now, but they kind of work the same way. And in the case of this label revision, the FDA was suggesting genotyping when the drug was being considered for specific, excuse me, for specific information that would give you basically a therapeutic drug range. So yeah, for what it's worth, it didn't really help that much with clinical decision making. Some other tools have come into play that have been more useful, but you could see the information right there. Okay. We have about 15 minutes left for this section, and so this is perfect timing to introduce the use of pharmacogenetics, pharmacogenomics, and applications. And then I'm going to give you some things to think about and some things to write about. So for those of you who may want to listen with me, you're more than welcome to stay. If not, the link is there. You can listen on your own to this little segment. And then there are questions on slides 92 and 93 to consider. And what I want to ask you to do is to pick a couple of those questions and respond to them, and maybe send me that as an individual post, or you can use a group post in Canvas as you need to. So this is it's 14 plus minutes. Let me go ahead and get it started. So I'm going to stop sharing for a moment and pull up the here it is. Okay. Here we go.
You're listening to Shortwave from NPR. When you think of resources on Earth, what do you think of? Maybe you think about water or oil, timber, perhaps. What about data? Our data, the information stored in our DNA.
Genome sequence data itself can be used and aggregated as a resource. In that sense, it's no different than diamond mining, coal mining, right? Like it is a resource. And in fact, we should start treating it as such and recognize its value.
That's Keolu Fox. He's a professor at the University of California, San Diego, and a genome scientist.
I mean, I've been thinking about diversity and genetic variation for pretty much my whole life as a Hawaiian person. You know, my ohana, my family is from the big island of Hawaii, and this is a place that has it just tremendous biological diversity.
Over the years, Keolu's worked on projects gathering and comparing DNA sequences, often in hopes of finding a genetic cause of a disease or even developing a treatment. But early on in his career, he noticed this research left a lot of people out. Like the one time he realized none of the participants in a study were Polynesian.
And that made me extremely upset. It was like the boat had left for the future of predictive and preventative medicine, and my people weren't included on the boat. And I remember like digging into that question like a pit bull on a bone. That's how I kind of stumbled upon a lot of these statistics and numbers.
At the time, 96% of participants in genome studies were of European descent. 96%.
And that just lit a fire under my ass. And I knew that was going to be my calling.
So that's what Keolu focused on, increasing the participation of minoritized communities, especially indigenous communities, in genetic studies and databases. But here's the thing. Eventually, Keolu figured out that wasn't enough. This wasn't just an issue of representation, but one of indigenous data sovereignty.
Understanding who is in control of that data, who is protecting it, who provides access to it. How do we put communities in a position of power and control? So they're controlling the resource so that they benefit greatly from that.
Today on the show, rethinking ownership in genomic science, how to make the field more accountable and create an equitable future. I'm Maddie Sophia, and this is Shortwave from NPR. So before the break, we talked about how Keolu first noticed a lack of diversity in genomics. He was working with these databases and noticed a lot of minoritized communities were left out. And as he began to interrogate that, he made two key observations.
One of the reasons is more around comfort and convenience. It's like if you are a Western European ancestry doctor, it's much easier for you to recruit white people within your network, right?
Sure.
And then on the other side of the coin, it's really hard to recruit communities of people who have historically been exploited.
Exploited by the medical and scientific community, traumatizing experiences with lasting impacts, like what happened to the Havasupai tribe from Arizona. So back in 1989, researchers at Arizona State University and the Havasupai agreed to partner up to determine if there was a genetic reason behind the really high rates of diabetes that have plagued the tribe for decades.
But when Arizona State turned around and questioned the Havasupai Nation's origin story, tried to look for genetic associations with schizophrenia and assessing mutations that are associated with interbreeding, it naturally pissed off the community because that's not the arrangement and the consensus that they built.
Not only did the researchers not get consent to look at those things, some of those questions in themselves deeply disrespected the tribe's most sacred beliefs.
So that resulted in the sort of ripple effect or domino effect with many other tribes in the United States of America putting a moratorium on genetic research, which stands to this day.
Here's the other thing. It's become more and more clear that a lot of times these health disparities, like diabetes and the Havasupai tribe, aren't really even because of genetics. They're more about socioeconomic factors like access to healthy food and healthcare.
A lot of the times when indigenous populations or brown, black, and underrepresented populations of people are recruited into studies, it's under the guise of reducing health disparities and sort of pandering towards this narrative that there's an innateness to why our communities have higher rates of common complex disease, right?
Mm-hmm.
And that's highly problematic. And I have sold that grant narrative in so many grants and papers. And that's how I've kind of come to this position of questioning it and being skeptical of what the actual benefit has been.
A lot of people that have given up their DNA for these studies haven't really benefited that much. In fact, many genomic studies have yet to actually result in drug therapies. And even when they do, that doesn't necessarily mean participants get easy access to them.
In the case of cystic fibrosis drugs developed by the company Vertex, these drugs hit the market and they're $300,000 a year, which basically panders towards our broken healthcare system and our broken insurance systems. And we need to take stock of our values and understand why that's the status quo. Like, how is this happening in the United States of America in 2020?
Right. So the idea, Keolu, is essentially that even if the communities that are being asked to give their DNA to these studies, even if a drug is made that maybe could help with some condition that's in the community or whatever, that doesn't necessarily even lead to those communities having access to that drug or, getting any kind of cut of whatever money they make from that drug.
That's right. Yeah. Even if a blockbuster drug is developed using DNA and, mutations that were discovered in a population that earned those through their diaspora, that doesn't mean that they're going to receive any benefits or royalties from the drug. It doesn't mean that they're going to receive subsidized access to that drug. And in a lot of cases, we're talking about communities that don't even have healthcare. So how would they receive access to the drug in a broken healthcare system in the United States of America?
Let me ask you this, Kaylu. If you had the ability to start over and say, these are the ways that we are going to be more effective and to work more equitably with smaller communities that have been minoritized, that have been exploited, like if you could do it all over and say, this is the right way to do it, how would you do it? How should this research be done?
That's a great question. If I was to do it all over, I would build projects around something called benefit sharing. If we use benefit sharing as like our centering point of development and a philosophy or an idea that if we create revenue around the development of a mutation, whether it leads to the development of a blockbuster drug that's found in a population in Nepal or something like this, right? We need to think about circular economic structures that benefit the community. So will 5 to 10% of the royalties developed from data derived from X community go back into a community trust? And will that community trust then be used to support conservation projects, cultural revitalization programs, medical healthcare programs, education programs, efforts to buy back land that was originally tended to and protected by those indigenous communities?
To Keolu, this is all about breaking down systems of colonial exploitation, which means you can learn lessons from other industries that have started to address some of that damage. Specifically, he points to the progress that some in the diamond industry have made.
You can look at all of the progress since the 1980s to now in the way that the Botswana government has been involved in creating circular economic systems with local diamond mining companies and foreign diamond mining companies, some of which are in Canada. And they've been able to create benefit sharing models that directly benefit the communities in Botswana.
Yeah.
And I think that is just tremendous.
If this all sounds cut and dry, that's because for Keolo, it is. Replace the old system with one where communities giving their genetic info are able to collaborate throughout the process and get something out of it.
I mean, even more simply put, have you ever heard of Robin Hood? Steal from the rich and give to the poor?
I have indeed heard of it, yes.
Yeah. So if anything comes out of this, and what our, listeners need to take away from it is like when we develop these drugs, I mean, it's really serving a handful of stakeholders disproportionately. Why can't we redistribute some of that money to the communities and build real, authentic community-based programs, or engage them as stakeholders and stockholders in the development of drugs that are derived from their genomes? That doesn't seem that crazy to me. Call me the Hawaiian Robin Hood of genomics, but I think that's the future. That's the path towards a more equitable, socially, culturally sustainable modality of creating partnership agreements that involve federal governments, private industry in the form of big pharma, and communities.
Right. So I'm thinking about how you are a native Hawaiian, you are a scientist, you are a man, you are all of these identities. And I'm wondering, you're part of the field of genomics that has exploited communities, like the one that you come from.
Right.
So what has that experience been like for you just simply existing in this field?
Yeah, that's a great question. We do occupy, multiple identities, and you oscillate between like your kuleana and values as a Hawaiian person, in my case, for a lot of things, or your values as a genome scientist, or ways that you can actually use science to achieve justice and understand certain things. So initially, when I was younger, I started off as an archaeologist.
In this one project, Keolo got to examine the early life of Frederick Douglass, his life as a slave before becoming the great abolitionist.
And I remember thinking, here I am, a non-Black person, interpreting the material culture of one of the most impactful human beings in the history of America, the American lion, this abolitionist, and I'm not Black. And why do I have this privilege? And I remember thinking that. And that's something that I don't think a lot of my white colleagues go through. They don't think about what a profound responsibility it is and privilege it is to interpret the genomes of someone from a community that you're not a part of. I don't think that many of my colleagues have even reflected on what that means. It's just data to them. But you have to go through the motions of feeling uncomfortable and seeking and prioritizing new scientific questions that are actually going to have impact in the communities that you want to affect.
All right, Kayla Fox, I appreciate you. I appreciate your brain. Thanks for talking to us today.
Of course.
Today's episode was produced by Rebecca.
All right. Okay. So here are the questions for thought, food for thought, and writing assignment. When you have the opportunity to review this, here are some questions to consider. Think about what that circular benefit, what did he call it? Circular benefit system would entail. What is the cost of exclusion or non-inclusion of certain samples in genome studies? What are some issues associated with data sovereignty? Is it just data? And who does it belong to? Who should benefit from data derived from indigenous groups? How should the groups benefit from their participation in genomic research, and how to address the financial benefits versus the good of humankind, which could be limited to the good of investors, depending on what the research or the outcome is all about. What kind of system would you create? He talked about the system that he would create. What kind of system would you create to address the inequities described in this discussion? So I'm going to give you the afternoon segment is going to it's going to be 15 minutes shorter. So it's as if we're starting late or you're taking an extra long lunch. So you have the opportunity to consider these questions and write the answers to a couple, as I mentioned before. Um, if you can come up with other questions of your own, or if you have comments or other points that you want to make about what you heard or what you knew about this topic, I'm open to that as well. These are good questions, but they're not the only questions that could be answered about this topic. They're just a way to get you engaged and involved in thinking about what does it mean to do pharmacogenomic research and to use the results of pharmacogenomic research for clinical practice. So with that, I know I've gone a little bit over what I said I would do, but we're still within the allotted time for the morning portion. I will you will see the next segment being posted shortly. Thank you.